bleeding due to a violation of the superior gluteal artery or the vein?
I personally have not so far, fortunately, and in the IMEA case, we did have one revision that had to take place because of a hematoma in the gluteal muscles. Of course, I mean, you can argue that this might be from muscle trauma or from the gluteal superior artery, especially the deep branches, but it really happens rarely. And I actually, just to make sure, I do put drains in sometimes, but in general, it even works without drains, and rarely seen it. I haven't seen it at all, actually.
Okay.
Yes, I have a question. Yeah, on the diagram, it showed, you know, the implants being placed through the articular portion of the joint, all three of them. And that's a very good strategy, I agree. But most of the time when I see these done, they're not in that location. What is your experience, and how much do you spend time and energy making sure you get in that zone?
I personally think it's like a pedicular screw that's not in the pedicle. It's they simply belong into the pure joint and into the interarticular region. I would advise to revise if they are really outside, because they will only get stuck in the ligamentous portion. So I agree. If you see this, then I think it's not optimal, and it should be considered to revise if the patient has symptoms. If asymptomatic, you can leave these implants in, but I compare it to pedicular screws that are not placed correctly.
Thank you. Great presentation.
Thanks.
Julius, my concern is if you put all those three implants inside the cartilage-bearing part of the joint, and where they should be, they're quite close together, or might be quite close together. Have you seen fractures, or have you heard of fractures from other surgeons due to the fact that the implants are quite close?
I haven't had it, and we do have a post-operative CT on every image. The trick is to really make sure that they are apart, like 5 to 7 millimeters, and this actually works. I haven't seen these fractures. I know what you mean, but actually, even in the IMEA trial, this was not observed, and we did have an external radiologist working on this and doing the evaluation. So it seems to be a rare phenomenon.
In revision cases, what do you do with the holes that you get in the ilium if you have to take out 2 or maybe 3 of these plants?
Not actually, to be honest, nothing. I mean, if theoretically one can discuss whether one should place wax, bone wax or something like this, but I haven't discovered major bleedings in the revision cases I did, so I just leave the holes and, you know.
And what is the strategy? So what do you use instead of the triangular angular implants?
No, I then add. If I do not use the same hole again, then I add, as I showed, additional implants in areas that are still untouched.
And you fill up the holes with bone or something? Or
actually, nothing. No, I don't. If it would bleed, I would suggest bone wax, but it hasn't been a problem so far. Okay. But revisions are relatively rare, but you do see them if you work with the system. Yeah.
Do you recommend navigation for the first cases, or for which cases, like special anatomy that you know from a CT scan that you have, but do you recommend navigation for
only the tricky cases? I agree. I don't recommend for the beginning. The surgery is not that complicated. You are able to hit the target. And so it's perfectly fine without navigation. You have these inlet and outlet views. They almost give you a 3D sense. So, but yes, if you have tricky revision cases and you really need to hit this one spot, then yes, navigation helps.
With that, how important is it to capture like anteriorly in S1? Do you put a lot of effort into getting your first implant in that position?
Yes, I see this is something that people that have experienced the surgery really pay attention to often, because this is the longest implant you will place, and you really want to make sure this is in a good spot. So this is the one that gets closest to the alar line in the upmost corner. So yes, I guess this is the one I pay most attention to.
I have a question. I believe if in our facility we have navigation, probably that is much safer to use, because I used to do fluoroscopy and change it to navigation, and it made my life much easier. Than the smaller incision, I put percutaneous pin in contralateral pelvis and bring the turkey foot to locate my incision, and through one incision about 2 centimeters, I'm able to put my implant in, and I'm 100% sure the implant is going through the joint, especially try to capture the synovial part of the joint, that is most painful part of the joint.
Yeah, I do a kind of a poor man's navigation most of the cases. So I do it with fluoroscopy, and then I do a 3D intraoperative rotational X-ray. So then I see the position. But what you're saying, I think navigation really helps, and it's a matter of taste, but it helps you to come up with new trajectories that you would not use just when using fluoroscopy. So yes, it's an absolutely elegant way if you really want to get the longest contact through the joint in new trajectories. So yes, of course, it has advantages too.
Thank you.
Okay, if we don't have any more